This diagram is fantastic because it shows us that parasites can live in pretty much any part of the human body. And that's exactly why picking the right specimen is so critical. Let's just follow some of these lines. For parasites that affect the brain or spine, maybe something like amoebic meningioencephalitis, we're going to need cerebrospinal fluid, or CSF. For the lungs, where we might be looking for lung flukes or migrating larvae, sputum is the specimen we need. Over in the arm, a blood sample is key for diagnosing things like malaria, filariasis, or babesiosis. Moving to the body's core, the gut is a super common spot for intestinal protozoa and helminths, which makes a stool sample essential. The bladder can host parasites that cause urinary schistosomiasis, so for that we need a urine sample. For systemic infections that show up in tissue, like leishmaniasis in the leg, a tissue biopsy is what's performed. And finally, for parasites living on the surface, like scabies, we'd collect skin scrapings from the hand. You see, each location dictates a very specific collection strategy.
And it doesn't matter what specimen we're collecting, these 5 universal rules create this cycle of best practices that leads to what we call the zero failure standard. Let's walk around the circle. It starts with preparation. You absolutely must explain the procedure to the patient and ensure their privacy. Next up is timing, and this one is huge. Always collect the sample before any treatment starts. If you don't, the medication could kill the parasites and give you a false negative. Then comes the vessel. The sample has to go into a clean, dry, and totally leak-proof container. Fourth is identity. Label that container right away with the patient's ID, the date, and the time of collection. An unlabeled sample is a useless sample. And finally, velocity. Get that sample to the lab as fast as you possibly can. Following all 5 of these rules just drastically cuts down the risk of getting a false negative.
All right, so we've got the foundational principles down. Now let's see how this all plays out in the real world. We're going to apply these universal rules to some specific, common specimen types, and we'll start with one of the most frequent ones in parasitology, stool samples.
When it comes to stool collection, technique and precision are everything. Let's start with the prohibited actions, the big don'ts. The sample must have zero mixing with urine or water. Urine can actually destroy motile protozoa, and water can have free-living organisms in it that could be mistaken for parasites. Also, there should never be any toilet paper in the container because it can mess with the processing. Now let's look at the required actions. The sample has to be collected in a clean, dry pot, and that lid needs to be closed on there tightly to stop any leaks or contamination. And check out the timing. It has to get to the lab within 30 to 60 minutes if it's a fresh sample. Below that, we've got a really helpful quantity reference. For an adult, you need a walnut-sized amount. That's about 5 to 10 grams. For a child, a grape-sized amount, or 2 to 5 grams is good. And for an infant, a simple diaper smear is all you need.
So why isn't one stool sample enough? Well, this slide explains the 3-sample rule, and it's all based on a biological principle called intermittent shedding. Basically, this just means that parasites, especially protozoa, aren't passed consistently in every single bowel movement. Their numbers can go up and down. So as this timeline here shows, to get around this, the best diagnostic strategy is to collect 3 separate samples on alternate days, all within a 7 to 10-day window. Collecting a sample on day 1, another on day 3, and a final one on day 5 dramatically increases our diagnostic sensitivity. A single sample just has too high a chance of missing the infection entirely. So this strategic timing, well, it's non-negotiable for a reliable diagnosis.
Okay, let's shift gears from stool to blood, where timing, or what we call chronobiology, is just as critical, maybe even more so. This clock diagram is a perfect guide. For malaria, the parasites are easiest to find in the bloodstream during fever spikes, so collections have to be timed to happen right then. In contrast, filariasis shows what's called nocturnal periodicity. This means the microfilaria are circulating in the peripheral blood at night, so the best collection window for that is between 10 p.m. and 4 a.m. Trypanosomiasis is the one exception here. You can collect a sample for that at any time. Now let's look at the smear types over on the right. A thin smear, where the blood is spread thinly, is what we use for species identification because it preserves the shape of the red blood cells in the parasites. A thick smear, on the other hand, is a concentrated drop of blood. We use that for detection because it lets you screen a much larger volume of blood, which increases the odds of finding the parasites. Both of these are prepared immediately, either from a finger prick or a venous blood sample.
And beyond stool and blood, other fluids have their own specific rules. For urine, again, timing is key. The best sample is collected midday, between 10 a.m. and 2 p.m., or it should be the terminal urine, the last few drops, because that's where parasite eggs, like those of Schistosoma, tend to gather. You need about 10 to 20 milliliters. That sample is then spun down early in a centrifuge to create a sediment, and that sediment is what we examine under the microscope. For other sterile fluids, the collection method is tied directly to what we think the infection might be. We'll collect CSF if we suspect amoebic meningoencephalitis or trypanosomiasis. Sputum is collected to look for things like lung flukes, and a tissue biopsy is what's needed to diagnose infections like leishmaniasis.
You know, collection is really just the beginning of the specimen's journey. Once we have it, we immediately move into the next critical phase: preservation and transport. This is all about protecting that sample's integrity from the moment it leaves the patient until it finally arrives at the lab for analysis.
So the whole reason we use preservatives is to prevent two things: autolysis, which is the self-destruction of the cells, and morphological damage to the parasites themselves. The standard ratio, as you can see in the diagram, is 1 part sample to 3 parts preservative. This makes sure everything is thoroughly fixed. Now this table breaks down the common options. You have 10% formalin, which is great for preserving parasite eggs and cysts, but its big downside is that it destroys delicate trophozoites. Then there's PVA, or polyvinyl alcohol. It's the best for preserving protozoa, but it is toxic because it's mercury-based. SAF is a safer all-around alternative, and MIF is often used for quick field examinations. Each one has a specific job, and using the wrong one can completely compromise the sample.
Along with the chemistry of preservation, the physical conditions are absolutely critical. This table here gives us the hard limits for time and temperature. If we look at the clock, a fresh stool sample has to be processed in under 1 hour. Fresh urine gets a little longer, under 2 hours. And blood, that needs immediate processing. Preserved samples, on the other hand, are more stable. They can last from 24 hours up to several weeks. Now for the thermometer. Fresh samples should be kept at room temperature. If you need short-term storage, refrigeration at 2 to 8 degrees Celsius is okay. But, and this is the most important point, highlighted in red, you must never, ever freeze stool samples. Freezing creates ice crystals that will literally rupture and destroy the morphology of any parasites in there, making them totally unidentifiable.
Okay, so what if a sample needs to be sent to another lab? Well, safety and security during transport are guaranteed by something called the triple packaging system. This diagram shows the assembly order perfectly. Let's build it from the inside out. Layer 1 is the primary container. This is the one actually holding the specimen. It has to be watertight and sealed securely. This primary container then goes inside layer 2, the secondary container. It also has to be watertight and, this is important, it has to contain absorbent material to soak up any leaks that might happen from that primary vial. Finally, the secondary container is placed into layer 3, the outer packaging. This is a tough, rigid box that can handle the bumps and drops of transport. This whole system is the gold standard for making sure samples arrive safely and intact.
So we've collected and transported the sample safely, but the journey isn't over yet. Now it has to face the final quality gates right at the lab. This is the last line of defense, where every single sample is checked for contamination, measured against strict rejection criteria, and verified with a perfect paper trail. This table lays out the common contamination threats and the exact protocols to prevent them. Let's just run through them. Threat: dirty containers. The protocol: always wear gloves. Simple. Threat: urine and stool, which we know destroys motile protozoa. This is prevented by using single-use tools for handling the sample and giving clear instructions to the patient. Threat: water contamination, which can introduce free-living organisms. We avoid this by making sure all surfaces are clean. And the final threat: reuse tools, a huge source of cross-contamination. This is countered by strict hand washing and single-use policies. You see, each protocol directly targets a specific threat to that sample's integrity. So, what happens if a sample does arrive and it's compromised? It gets rejected. A result would be invalid anyway. This slide here is the gatekeeper, listing the criteria for an automatic rejection. A sample will be rejected if it's unlabeled or has a mismatched ID, if it's in a leaking container, if the specimen has dried out, if it contains obvious contaminants like barium or urine, if there's just not enough of it to analyze, or if it's in the wrong preservative. If any of these things are true, the protocol was crystal clear. First, you record the rejection in the log. Second, you inform the clinician immediately. And third, you request a recollection. The final piece of the integrity puzzle is meticulous documentation. This creates the paper trail, and it's absolutely essential for the chain of custody. This sample log shows the mandatory records we have to keep. We've got the unique lab number, the patient's name, the specimen type, in this case stool, the exact date and time of collection, the collector's signature or initials, the preservative used, like SAF, and finally, the specific test ordered, like an ONP for ova and parasites.
Every single one of these fields has to be filled out accurately to ensure we can trace that sample from start to finish.
So, we've now looked at all the individual pieces of the protocol. In this final section, we're going to bring it all together and see how these steps connect to form a complete, unbroken cycle of quality assurance.
This workflow summary just beautifully pulls the entire process together. Let's walk through it one more time. It all starts with prep, which includes patient safety and clear instructions. That flows into collection, which is all about anatomy and precise timing. Next is preservation, using the right stuff at the correct 1:3 ratio. Then comes transport, using that triple packaging system. The sample then arrives for reception, where it's checked against all the rejection criteria. And finally, it's entered into the log, which completes the documentation. And as the statement at the bottom says, strict adherence to this entire protocol is what prevents false negatives and, most importantly, ensures patient safety. Every single step is a critical link in that chain.